On a beautiful evening, after a heavy cornea clinic, our resident Pooh sat under a peach tree, reflecting on the day's events in the clinic. But something was bothering him. What was it? He had diagnosed a patient with dendrite and treated him with antivirals, but on follow-up, Master Shifu found that it had worsened and turned out to be a full-blown fungal ulcer. Pooh was very frustrated and confused, so Master Shifu asked him to meet after the clinic the next day. And the teaching began. Infectious keratitis stands as the 5th leading cause of blindness worldwide, affecting over 2 million people each year. Infectious keratitis can be microbial keratitis, caused by bacteria, fungi, parasites, or viral keratitis. A significant proportion of these cases arise in poor resource settings, like South Asian countries, highlighting the crucial need for early diagnosis and proper treatment. Diagnosing dendrites and pseudodendrites clinically is often challenging. Therefore, differentiating them requires profound knowledge and careful observation. Dendrites. The term dendrite comes from the Greek word dendron, meaning tree, which describes their branching pattern. Dendrites are linear epithelial defects with an arborizing pattern. They have raised epithelial borders with central ulceration and distinctive terminal bulbs at the ends of the branches. They manifest as microdendrites that coalesce to form dendritic ulcers and are classically associated with herpes simplex virus keratitis. Dendrites can deceive our eyes like certain creatures in nature that are hard to spot. They might not be visible under diffuse illumination, but their presence can be appreciated under focal illumination using a slit. Their visibility is enhanced with stains like fluorescin, rose bengal, or lissamine green, which helps to delineate them from the surroundings. Fluorescein dye diffuses through the disrupted intercellular junctions and epithelial cell loss and adheres to the basement membrane, therefore highlighting the areas of epithelial breakdown by staining the bed of the ulcer. Rose bengal or lissamine green dye have a high affinity to stain the dead and devitalized epithelial cells, thus staining the raised epithelial borders of the lesion that harbor the devitalized epithelial cells. Pseudodendrites. These are lesions that mimic dendrites but lack the characteristic dendritic pattern. The common differentials for pseudodendrites are fungal keratitis, herpes zoster ophthalmicus, and healing epithelial defect. Fungal keratitis is the most commonly misdiagnosed pseudodendrite. Let's do a Furious 5S test to differentiate them from dendrites. Symptoms. Fungal keratitis presents with severe redness, pain, irritation, and history of vegetative matter injury, while dendrites will have mild irritation only. Signs. Fungal keratitis will have congestion and edema, whereas dendrites will have a white eye. Fungal pseudodendrites lack the characteristic arborizing pattern and terminal bulbs of true dendrites. Stroma. The level of lesion is stromal in fungal and epithelial in dendrites. Stain. Fungal pseudodendrites may take up stain, but it will not be of a typical dendritic pattern. Sensation. Sensations will be lost in dendritic ulcers, whereas usually intact in fungal. Herpes zoster ophthalmicus. They are superficial and appear as branching patterns with blunt ends, giving a painted-on appearance. These lesions can develop weeks to months after the resolution of the skin lesions. They are more superficial than HSV dendrites and take up stains, but lack central ulceration, raised borders, and terminal bulbs. Healing epithelial defect. The migrating epithelial cells from the edges of the epithelial defect tend to form sheets of advancing epithelium moving toward the center. As these sheets come into contact with one another, an epithelial healing line is formed. This has the appearance of one or more Ys joined at the base, creating an appearance reminiscent of a dendrite. These healing lines take up stains, but lack the distinctive arborizing pattern and terminal bulbs of true dendrites. Special situations include recurrent dendrite and healing dendrite. Recurrent dendrite will have a stromal scar associated with a dendritic lesion. Fluorescein staining will help in enhancing the epithelial defect. In healing dendrites, there will be remnants of dendrite, but the stain will lack the characteristic dendritic pattern. Diseases may deceive us with their varied presentation. Differentiating dendrites and pseudodendrites can pose significant diagnostic challenges. However, through meticulous examination, we can distinguish them apart, thereby providing effective treatment, enhancing patient care. And yes, finally, our resident poo attained inner peace.